Hello, this is Maxwell Flitton, and running this simulation with me is Caroline Morton. Here we have Clinical Metrics. It's a virtual emergency simulation that has unlimited realistic patients. Here we can see that we're creating a new class. The diseases that are selected will appear in the simulation. Every time a random patient is generated in that simulation, the patient could have one of those diseases that is selected for the simulation. We then move on to the weighting of the scoring. Diagnosis is for getting the diagnosis right. Never events are for not doing incorrect things. That means excessive testing, such as a CT scan for pneumonia. And protocol is for doing the correct things, such as an ECG for chest pain. We are now logging on as a student. Here we're going to use the simulation that we have just made in order to see how the simulation actually runs. Here we have our unique patients waiting for us. Some have come by ambulance, others are waiting in the waiting room. We can select one, choose the room in which we want to assess them in, and start interacting with the patient. All the patient interactions, tests, and notes are logged in real time. Every interaction, such as a test or physical examination, will take turns. Every patient will have their own unique chatbot trained for their past med history, presenting complaint, and other factors. It must be noted that everything is logged, including every single piece of dialogue the user has with the patient. This facilitates a lot of cutting-edge research that you could potentially do with this. Like social media, you can analyze with great granularity how students and doctors are interacting with patients and what they're doing. Unlike social media, we're not selling your data. You have your own cluster where you have 100% control over your own databases. Some universities have used this to pull out data and write papers. One department found that their medical students were just not prescribing pain relief with certain conditions. Another finding was that a whole cohort failed to manage heart failure patients. This is because they were confusing them with respiratory conditions due to the shortness of breath. There may be multiple reasons why the whole cohort failed. Maybe the professor cardiologist was off sick. We don't know. But this prompted them to do extra training in heart failure. They managed to get a gauge of the whole cohort's ability very quickly and rectify the problem. Nothing is off limits for each patient. This means that you can choose from 173 different medications per patient if you want to give a medication. You can also choose between 9 different examinations of the patient in terms of the physical exams and 22 different investigations per patient, from ECGs to CTs to X-rays. You can also choose up to 62 different blood tests per patient. This is to give the user a very wide choice. It means that you're not guiding the user subconsciously in what's available to do to the patient, and it also gives you more of a feel for what they would actually do, which means that the user can actually overorder or order incorrect tests. You may have noticed a notification pop up. That was another patient coming in to be treated. Patients will keep coming in. We'll also have to wait for those blood tests and also scans to come back. Therefore, we have to manage multiple patients at the same time. This gives us a new dimension. Some departments have found that their users get flustered when there's too many patients and they start to cut corners. They've also found others who hyper-focus on one patient whilst ignoring the pile-up elsewhere. This is something that just gets better with practice, and it's hard to facilitate without this software. The consequences are quite bad if we let the student and junior doctors just pick this up on the ward as real patients suffer. Plus, they don't get the same intensity of exposure if you just have to rely on raw experience in the hospital. Raw exposure in the hospital also doesn't have the same granularity. When we collect data in the hospital, it is often messy. For instance, I remember when I was in A&E, I would sometimes treat a patient and then write notes later on. It's hard to work out exactly what is happening and when, and our memories are quite bad. So if we want to do a true post-mortem on why something piled up or why someone made a mistake, we can actually analyze this in a statistical nature. which just can't be achieved when trying to reconstruct what happened on the ward or in the accident and emergency department. There is also a counter for patients. Therefore, if you don't do anything to your patients for quite a while, they do start to deteriorate, so you do have to intervene at some point. At the end, when you discharge a patient or admit them, you'll get a feedback and a summary of what you actually did and a score. We are also working on integrating ChatGPT into analysing the chat logs. You won't be directly interacting with ChatGPT as this can be unpredictable. But ChatGPT is quite good at reading what's written and then saying what was actually written. So we can actually use ChatGPT to analyse the chat logs between the patient and the user. We are close to integrating real-time events as opposed to turn-based operations. This will enable teams of users to interact with the same groups of patients. So we can analyse teamwork and see how they actually manage larger groups of patients. This will enable people like registrars and consultants to practice their leadership skills. We are also working on integrating disaster models. These are already well represented in financial and insurance modelling. We can use the 3D modelling along with arbitrary cutoff points and Monte Carlo sampling to calculate the risk of a certain type of patient being presented in a certain geographical space based on a realistic model of, let's say, an earthquake or a flood that banks and insurance companies actually use in production. We'll be using the same open data standards as OASIS LMF, which is the loss modeling framework. If we combine real-time events and teamwork with a geographical plane that actually produces trauma patients or other types of patients in geographical areas, we can actually have a comprehensive simulation where patients are realistically generated based on a real-life model. They take time to get to certain hospitals, and then you'll have teams in those hospitals actually interacting and managing patients. If we do simple restrictions based on the type of hospital or department in terms of what tests you can do, then we can also encourage and see how clinicians handle transfers of patients. Therefore, we can get a fully comprehensive simulation that would essentially cost millions to perform if we were going to use actors and we were going to take over entire hospitals. What's more is that we still get that granularity of data. Therefore, we can do very advanced analytics that we just wouldn't be able to do with the more expensive options. This is it for now, and it's been a pleasure showing you how the system works. If you want any research collaborations or simply just want to use it to help your F1s or medical students, please contact either Maxwell Flitton or Caroline Morton in the LinkedIn links in the description.